Good evening. I'm Sona from Kottayam Medical College.
Good evening. I'm Dr. Sudhina from Kottayam Medical College.
47-year-old lady, housewife, resident of Kottayam, presented with complaints of swelling in right breast for 5 months. History of present illness. Patient was apparently normal 5 months back. Then she noticed a swelling in right breast, which was insidious in onset. Initially, swelling was approximately 2 into 2 cm. Then there is a rapid rise in size in last 3 months to attain the present size of approximately 6 into 5 cm. No other swelling in same breast or axilla. No complaints of swelling in opposite breast and axilla. No history of pain. No history of trauma to breast. No history of any discharge, ulcer or skin changes in breast. No history of bone pain, bony swellings, seizures, jaundice. No history of chemotherapy or radiotherapy. Past history. She was diagnosed to have kidney disease on evaluation for frothy urine, swelling of hands and feet, and decreased urine output 3 years back. Was started on oral medication. Hemodialysis was initiated 12 months back via right IJV twice weekly. Now hemodialysis was done twice weekly through AV fistula in left forearm. No history of catheter-related complications. No history of decreased blood pressure, breathing difficulties, itching or allergic manifestation during dialysis. No history of hematemesis, melena. No history of generalized pruritus or easy bruisability. No history of chest pain, dyspnea, orthopnea, paroxysmal nocturnal dyspnea. No history of recurrent infections, palpitations, syncope, muscle cramps, numbness or tingling sensation. No history of seizure, memory loss or altered sensorium. No history of hypoglycemic episodes. No history of heartburns, regurgitations, chronic cough, laryngitis, hoarseness of voice or dental enamel erosions. Last dialysis was done yesterday from 8 p.m. to 12 a.m. Ultrafiltrate removed is 1.5 liters. She's a non-case of type 2 diabetes mellitus for 12 years, was on irregular medication and glycemic status was uncontrolled. Now on insulin for last 3 years. Non-case of hypertension for 10 years on regular medication. History of AV fistula in left forearm 1 year back under local anesthesia. Intra and posterior period was uneventful. No history of coronary artery disease, COPD, bronchial asthma, thyroid disorders, pulmonary TB, seizure disorder, CVA, POVD, or no history of jaundice. No history of chronic analgesic intake. No history of previous surgeries and ICU admissions. No history of drug or food allergies. Her MES more than 4. She is able to climb 2 flights of stairs. Drug history. She is on tab Nicardia retired 20 mg TID, tab Arcamin 100 microgram TID, tab Metalar XR 50 mg OD, tab sodium bicarbonate TID, tab torsemide 100 mg BD, tab Randac 150 mg BD, tab calcium acetate BD, tab Atorvastatin 10 mg HS, injection Epotras 4000 international units twice weekly. Injection human Vistat 15 units BD. Regular dialysis done thrice weekly. Personal history. She is housewife. Menstrual history. Menarche at 15 years. Menopause at 45 years. Married. 2 children. Normal vaginal delivery. Takes mixed diet. Normal sleep. Decreased appetite. Decreased urine output. Around 400 ml per day. Bowel habits are regular. No addictions. Family history. Her mother is diabetic. No history of kidney disease in family. No history of malignancies in family. Summary. 47-year-old female. Non-case of systemic hypertension for 10 years. Diabetes mellitus for 12 years. CKD for 3 years on hemodialysis. ASA class 3. Presented with complaints of paleness swelling in right breast for 5 months. Probably carcinoma right breast. Positive for right modified radical mastectomy. General examination. She is conscious, oriented, cooperative, lafebride, pala plus, no pedal edema, no icterus, cyanosis, clubbing or generalized lymphadenopathy. AV fistula in left forearm, radiocephalic mithril, height 160 cm, weight 56 kg, BMI 21.2 kg per meter square, dry weight 54 kg. Vitals, pulse rate 88 per minute in right radial artery, regular rhythm, normal volume and character. Peripheral pulses felt normal. Condition of vessel wall normal. No radial or radiofemoral delay. AV fistula in left forearm mithril. BP right upper limb 140 by 90 millimeters of mercury in sitting. 130 by 70 millimeters of mercury in standing. Respiratory rate 18 per minute, regular, thoraco-abdominal. Saturation 99%, room air. Then airway examination. Mouth opening 4 centimeters. Myometry class 2. Thyromental distance more than 6.5 centimeter. Temperamental joint mobile and 1 finger insinuation possible. No loose tooth or artificial dentures. Good oral hygiene. Neck movements normal. Present negative. Local examination. Inspection. Examination of left breast normal. Examination of right breast. Right breast is enlarged in size compared to left breast. Nipple and areola normal. Skin over breast normal. No edema of arms or fullness in supraclavicular or axillary areas. Palpation. Left breast normal. Right breast no local rise in temperature tenderness. Palpable swelling in upper quadrant of size 6 into 5 centimeter. Irregular in size. Hard in consistency. Not fixed to skin or underlying structures. No lymph node palpable. Systemic examination. Cardiovascular system. Inspection. Precordial normal. Apex vein not visualized. No engorged vein. JVP not elevated. Scar of old IJV catheter on right side of neck. Palpation. Apex vein 5th left intercostal space. 1 centimeter medial to midclavicular line. No parasternal heel. Percussion. Cardiac dullness noted in left 6th intercostal space. Right heart border corresponds to right sternal margin. Left heart border corresponds to apical impulse. Auscultation. S1, S2 normal. No murmurs. No carotid void. Upper respiratory tract infection examination. No sinus tenderness. No DNS. No nasal polyp. Oropharynx and tonsil normal. Inspection. Chest normal in shape and symmetry. Trachea appears to be centered.
If you don't have any positive findings, you can stop here and come to the diagnosis.
See, 47-year-old diabetic hypertensive female, CKD stage 5 on hemodialysis with locally advanced carcinoma right breast, clinical stage T3 N0 M0, stage 3 for modified radical mastectomy.
Thank you for that detailed presentation. So you have a patient with CKD. I would like to know how you came to the diagnosis of CKD. What are the factors that you considered before making the diagnosis of CKD?
She presented with She had history of proteurine and decreased urine output 1 year back. Then she was diagnosed to have increased creatinine and urea level and diagnosed as CKD. She had similar symptoms for more than 3 months with decreased urine output and 3 years.
She's on hemodialysis for the last 1 year. Diagnosed 3 years back.
3 years back.
Okay.
Okay, so what are the factors that you consider? Criteria for diagnosis of CKD. There are nearly 5 factors which are used. What are they?
CKD is defined as structural or pathological functional abnormality of the kidney. It can be manifested either as a pathological structural damage or abnormalities in the manifested as biomarkers like in blood, in urine, or in the imaging studies, with or without fallen GFR. Or it can be fallen GFR less than 60 ml per minute per 1.73 meter square per kilogram for more than 3 months, with or without kidney damage.
Anything else?
Albuminuria. Based on albuminuria, albumin creatinine ratio, CKD can be classified into 3. That's A1, A2, A3. That is mild, moderate, and severe. A1 is ACR ratio, that is albumin creatinine ratio, from less than 30 milligram per gram of creatinine. Or moderate is 30 to 300, and severe is more than 300.
Okay. Then?
Based on GFR, the CKD can be classified into 5 stages. First one, stage 1, that is GFR more than 90 ml per minute per kilogram per 1.73 meter square. Or stage 2, that is mildly decreased, that is between 60 and 89. And stage 3 can be A and B. Stage 3A is 45 to 59. And stage 3B is 30 to 44. And stage 4 is 15 to 29. And stage 5 is less than 15 ml per minute per meter square kilogram.
Any other factors are used to define CKD?
Novel biomarkers can be
Biomarkers.
used. Novel biomarkers can be used. Serum cystatin level, uromodulin.
No, let's not go to cystatin levels. Other than that, the presence of tubulointerstitial disease is one. Then, if the patient is on dialysis or if the patient had undergone renal transplantation, they are considered as CKD patients. Okay, right. Let's not go into history and examination. Let's see what are the problems that you expect, the anesthetic problems that you expect. What are the risk factors that you have in these patients?
Regarding the anesthetic concerns, first we have the patient is having multiple comorbidities like diabetes and hypertension. So we have to optimize the patient regarding the comorbidities, like optimize the glycemic status. Then we have to treat the hypertension. Then we have to allay the anxiety of the patient as the patient is with malignant disorder. And there is high risk of aspiration for the patient since the patient is diabetic as well as CKD. And there is risk of autonomic dysfunction. So hemodynamic stability is of prime course. Then perioperative fluid therapy is of major importance, and electrolyte balance as a base imbalance can occur. Then
What is the electrolyte disturbance that you see?
in CKD, there can be hyperkalemia, hypocalcemia, hypermagnesemia, hypo or hypernatremia depending upon the fluid status, hyperphosphatemia.
Yes.
High anion gap, metabolic acidosis.
How we do
Other
strategy?
systems? Any other systems? Cardiovascular system, what are the problems?
In cardiovascular system is the main concern regarding a patient with CKD, and there can be hypertension, then left ventricular hypertrophy, concentric LPH, uremic cardiomyopathy, then pericardial effusion, pericarditis, then systolic or diastolic dysfunction, then congestive heart failure, then valvular stenotic lesions.
What about ischemic heart disease?
Yeah, very high prone for ischemic acid because there is augmented atherosclerosis in a patient with CKD.
Okay. Coagulation?
Mainly the platelet dysfunction is the main cause of a patient with CKD. Main cause of bleeding in a patient with CKD. That is, routine coagulation tests such as PTINR, ABTT can be normal, and platelet count can also be normal, but there will be platelet dysfunction because of the decreased production of von Willebrand factorate complex.
Can they be prothrombotic?
Yeah, because there can be increased loss of thrombotic proteins through the urine, through the kidneys, and also there can be increased protein to proteinase ratio as well as antithrombin 3.
Due to
So that can
deficiency of antithrombin 3
3
and increased level of fibrinogen.
Okay. Anything else?
The chronic anemia.
Hemophilia, yes.
The chronic anemia, because of the decreased production of erythropoietin and because of GI bleeding, there will be increased risk of chronic anemia. Then unpredictable intravascular volume. There will be neurological complications like autonomic dysfunction. Peripheral and central nervous system might be impaired.
This patient is on dialysis.
There will be uremic encephalopathy will be there in severe cases.
What is the other syndrome that you see? On a patient who is on dialysis, what is the CNS problem?
Dialysis dementia, dialysis disequilibrium syndrome.
Yeah, there are two separate ones. Dialysis dementia. What
It's
is
because of the
is it seen now? Dialysis
No,
dementia.
because we are not using aluminum-containing dialysis. It's not common now. Then dialysis disequilibrium syndromes are seen in patients during the initial to hemodialysis because of the altered urea level in blood and brain, leading to cerebral edema due to the reverse urea effect.
Okay. Now, with this in mind, what all investigations are you going to do for these patients? This patient who is coming for a mastectomy. Okay.
First, I would like to send complete blood count, including hemoglobin, because there is a risk of anemia. Then total count, because there is high risk of infections because of the immunosuppressive status. Then I will look for the RFT, that is renal function test, blood urea and serum creatinine. Then I will look for the coagulation profile, PTANR, APTT, and bleeding time and clotting time can also be checked in this patient. Then I will look for serum electrolytes, sodium, potassium, calcium, magnesium, and phosphorus has to be looked for. Then viral markers, HbA1c level, FBS level, and on the day of surgery, we have to check the
One thing I would like to know, which is the most important complication that these patients can have?
major adverse cardiac events.
Cardiovascular. So how will you assess these patients for cardiovascular disease? They can have occult cardiovascular disease. So how will you assess the patient for cardiovascular system?
From the history, we can ask for any history of prior cardiovascular or any history of angina, chest pain, breathing difficulty, or aggravation of breathing difficulty during night, or any postural variation with that. And also, we can ask about the effort tolerance of the patient. And then we
Metabolic equivalence. isn't it?
metabolic equivalence. And then we can look for the ask for ECG and can look into any ACT changes or any signs of left ventricular strain pattern or left ventricular hypertrophy. And then we need a detailed cardiological examination for this patient since the patient is non-CKD.
Any risk assessment? What risk assessment will you use for this patient?
For this patient, I would like to use revised cardiac risk assessment, risk index, RCRA index has to be done. And it includes
Okay.
any history of, if the surgery is of high risk category, that is intraperitoneal, intrathoracic, or suprainguinal vascular surgeries. And any history of congestive heart failure, history of ischemic heart disease, history of cerebrovascular accident, or patient diabetes mellitus on insulin, or serum creatinine level more than 2. Each carries a score of 1, and if the score is 0, then there is 0.4% risk, and if the score is 1, there is 1.41% risk of cardiovascular events, and the 0.2, there is 2.4% risk. Here the patient has score of 2, so there is 2.4% risk. So if a patient has more than 1% risk, we can categorize it as a high-risk patient.
High risk
for major adverse cardiac events.
Okay. Will you do an echocardiography for this patient?
Yeah.
What
In
information?
echocardiography, we would like to evaluate we would like to know the ejection fraction of the patient, then regarding the concentric LVH, septoventricular hypertrophy, about regional wall motion abnormalities, then about pulmonary arterial hypertension, then pericardial effusion.
Okay.
Okay. Was there anything that you found in this investigation in this particular patient? Nothing. Okay. So now you have a patient who is coming for mastectomy. How are you going to optimize this patient?
Optimization of this patient.
Of this patient.
Yeah. Before you take up the patient, you have to optimize the patient. How are you going to do that?
I'll first allay the anxiety of the patient, then I will first optimize the comorbidities associated with this, that glycemic status, then hypertension, and then I will optimize the fluid status by regular dialysis and pre-op dialysis, and also the electrolyte imbalances can be optimized by the dialysis. Then I will advise to continue the antihypertensive
Any
drugs on the
infections?
day of
Any
surgery,
infections that has to be
then
corrected.
treated. Then
Optimization involves initiating or modifying the drugs that they take and optimizing the medications. So how will you do that? What are the medications that she's taking?
She's on antihypertensive to optimize the BP, blood pressure prior to surgery.
Hypertensive.
She's on Nicardia, tabaracamine.
Nicardia, how does it produce any anesthetic problems? Do you expect any anesthetic problems?
Calcium channel blocker.
Calcium channel blocker, yes. What type of calcium channel blocker?
Non-dihydropyridine.
Dihydropyridine.
Okay.
Dihydropyridine calcium.
Okay. What are the non?
Verapamil and diltiazem.
Verapamil and?
Diltiazem.
Okay, right. What is the difference between those two? Dihydropyridine and non-hydropyridine. What are the difference? What is the reaction on the sinus node? One produces bradycardia, one
What?
produces
Brady-
not much effect. Which one produces which?
Known
Verapamil, what does it do? Produces
bradycardia.
bradycardia. Okay, it has got action on the sinus, right? Whereas the dihydropyridine has got more action on the smooth muscle.
Peripheral vascular resistance decrease.
The other one has got more action on the cardiac fibers. Okay, fine. So what is the problem with the anesthesia? Is there any problem at all?
Yeah, majority of our anesthetic drugs causes bradycardia. So
It produces
here
vasodilatation. So it can
Hypotension.
interfere, it can produce hypotension. It is a calcium channel blocker. So theoretically it can increase the effect of muscle relaxation.
prolongation.
And it can interact with some of the agents that you use, like magnesium. It has got synergistic action with magnesium. That's the problem with nicardia. Right. What is the other agent? Other
Other antihypertensive.
She's an aracamine,
Arcamin, yes. Arcamin is
alpha agonist, centrally acting alpha agonist.
alpha.
Alpha 2 and
Okay. What is the problem?
there will increase risk of hypertension intraoperatively, and also if we stop the drug abruptly, there will be rebound. How hypertension will be there. So we want to continue the drug on day of surgery.
Okay. So the rebound hypotension is a problem. Okay, then any other problem with the anesthetic? Does it alter the anesthetics? Alter the anesthetic action? It's a alpha 2 adrenergic agonist, isn't it? It can actually produce
Excessive sedation can be
sedative
produced by
anesthetic action. Okay. It's something like Dexmed.
dexmedetomidine.
Okay, right. Okay. Then what is the other drug? So we'll continue those drugs.
Okay.
Is there a need to increase or decrease?
Is there any need to increase or decrease the dosage? Patient is stable, no? BP is controlled.
Now she's
So-
Okay.
Then there is
Right.
titrating drugs.
Okay. You have
Patient is posted for modified radical
Radical
mastectomy.
mastectomy.
How you are going to proceed? What advice will you give to the patient?
We will give advice to give compliance with the drug and continue the drug on the day of surgery.
And anything else that you will do? Patient is on
regular hemodialysis.
So-
and she had to undergo hemodialysis within 24 hours prior to surgery and 6 hours prior to surgery. Within 24 hours and 6 hours prior to surgery. And she had to do all blood investigation after the dialysis. And he had to continue all medications, all antihypertensive on day of surgery. Then inform her regarding the NPO status, risk and explain her about the risk of surgery and risk of postoperative complications.
what?
Are you going to premedicate?
Yeah.
What premedication?
On the POP day also we have to give aspiration prophylaxis because this patient is high risk for aspiration. So I would like to give tab metoclopramide 10 mg and tab ranitidine 150 mg, HS on the day before surgery and 6 a.m. on the day of surgery. And to allay the anxiety, I would also like to give tab alprazolam 0.25 mg, HS day before surgery. And she has to skip the morning dose of insulin and repeat FBS, serum electrolytes, and urine acetone on the day of the surgery.
Okay. Before you take the patient into the OT, how will you prepare the OT for this patient?
In the operation theater, I would first like to ensure that all the monitor is working properly and all the standard ASA monitors are available, including ECG, NIBP, SpO2, and ETCO2. Then I would like to check the machine. Then I would like to make sure that suction apparatus is ready and working properly. And I will load all the anesthetic drugs and intravenous fluid. I prefer here to use ringalactate if the serum potassium level is within normal limits. And all the emergency drugs will be kept ready. Then
See, before you take the patient for surgery, will you examine the patient for
yeah,
what?
after After preparing the OT, I will go and check the patient. I will confirm the NPO status. I will confirm that consent is signed or that. Then I will examine the patient for any sites of hypovolemia or hypovolemia. There is after dialysis, there can be chances of hypovolemia or inadequate dialysis can lead to hypervolemic status and
how
fluid
will you
overload.
assess that the patient is having hypovolemia?
I will auscultate for any fine crepes on the basal crepes, and also there can be if there is hypotension, there can be tachycardia, and BP has to be measured if there is any hypotension, or orthostatic hypotension can also be measured. Skin turgor.
Then you take the patient to the OT, no? Right? How will you go about inducing this patient? What? No, no. Before that, what?
First, attach all ASA, standard ASA monitors,
Okay.
ECG, NIBP, saturation. Then secure an IV cannula on the right lower limb initially.
What is the rationale? What is the rationale of putting an IV line?
Where are you going to put the IV line?
Putting the IV cannula in right lower limb because we can't cannulate the left upper limb because she has already in left AV fistula in left upper arm, and right upper arm she is undergoing right MRM. So we are not preferring to use right upper limb also. So we are cannulating the left lower limb, then applying the NIBP on the left lower limb.
Okay, that's the standard is that not to put a IV line on the MRM side. But I think there are few studies which have come and shown that actually it doesn't matter. Okay, but because of surgeons insist on that, I think we have to go for a lower limb cannula. Okay.
Then patient
What other precautions will you take before you position this patient?
I will first palpate for the thrill of the AV fistula and pad it and secure it, and intraoperatively we have to palpate for the thrill and make sure that it is patent and no thrombosis there, because hypotension and all can lead to thrombus of the AV fistula. And
You will also continue to check whether the thrill is present throughout the surgery. Okay, right.
Then the patient will be kept in supine position, and so pressure points should be padded regarding the occiput, then olecranon, sacrum, calcaneum, and then I will pre-oxygenate the patient. Then
What are
with
goals of
frame-
anesthesia?
Goals of anesthesia is to allay the anxiety of the patient, to avoid aspiration, to prevent any episodes of hypoxia, hypercarbia, hypotension, hypoglycemia, hypothermia, and judicious use of fluids, avoid hypovolemia or fluid overload, and post-op analgesia. Then
What about the use of
avoid
drugs?
prolongation of neuromuscular blockade, and exaggerated response to the drugs, especially with induction agent and neuromuscular blockade, which can lead to hypotension.
So,
And-
okay, what is the drug you are going to use?
For induction, sir,
Injection.
I prefer to use titrated doses of use propofol, especially with titrated doses.
What precaution will you take when you use?
Exaggerated hypotension.
Why do you prefer?
Because another agent is a thiopentone. No, because patient is on usually hypertensive, and propofol is a preferred drug for that. And with thiopentone, its PKE is weakly acidic drug, and and it's also protein-bound fraction is more. So here the patient is having hyperproteinemia, so increased free fraction of the drug, and also since since the drug is weakly acidic, in chronic acidosis, the free active form of drug will be more. So exaggerated hypotension can be there with thiopentone.
So you induce with propofol, and when you induce with propofol, suddenly there is a hypotension. Why does it happen? Why did that happen?
Autonomic dysfunction is there. So
No, no,
the
more importantly, what is it?
hypovolemic status.
Hypovolemic status. Due to? You
Okay.
already said that. Due to
Hypovolemic status due to dialysis
dialysis and
and prolonged NPO time. Autonomic dysfunction.
or it may be due to sometimes they are also on diuretics. Like this
Diuretics.
patient also was on diuretics. So that
And multiple antihypertensive drugs, including clonidine.
what is the other cause? Autonomic imbalance. Then
Fast.
maybe
Cardiac-
because your anesthetics itself, isn't it? Okay. Right. Any other reason? Maybe because of the antihypertensive the patient has. All this put together can produce hypertension. How will you manage it?
Hypertension. If patient is
Vasopressin.
vasopressor is a mainstay of treatment in a patient with CKD. Because we cannot give extra fluids because that may require if there is fluid overload, that the only treatment for that is
You're not going to give
hemodialysis.
fluid. You're not going to give extra fluid.
We can intraoperatively can give fluids to maintain the.
No. When you have hypertension, how are you going to manage? What is the way you are going to manage that hypertension?
Preoperatively, if there is no signs of hypertension, dehydration, then I will prefer to use vasopressors. Then otherwise, once a drug wean off, there can be normal tension, and at that time, that can lead to fluid overload.
We are suspecting hypertension.
So you have given propofol. Then what is your? Are you going to intubate this patient? Are you going to use a supraglottic airway?
Are you going to intubate this patient or use supraglottic airway device?
I will intubate this patient because the CKD patients are high risk for aspiration, so we have to secure the airway. So supraglottic airway devices have a risk for aspiration. So I will go with endotracheal intubation.
This patient is going to be only in supine position most of the time,
Yes.
unless there is going to be a flap that is being. I don't think there is any problem in using a supraglottic airway.
Which supraglottic airway device will you use?
Second generation IGL can be used. In case because it's a minor surgery, we can use supraglottic airway also.
It can be used. It can reduce the amount of surgical anesthetic the airway induced stress. Okay. You have intubated, ventilated. What is the goal during the surgery? What kind of anesthetic are you going to give? Are you going to use
Maintenance of anesthesia. How will you maintain anesthesia?
Anesthesia with the nitrous oxide, oxygen, and isoflurane. Then citalopram is used for neuromuscular blockade, given as 1.5 mg per kg bolus. 0.5 mg per kg bolus.
Will you use vecuronium?
No.
Huh?
No. Vecuronium, it's 40% of the vecuronium is metabolized and excreted through the kidney. So there has been studies, that chance that prolongation of the neuromuscular blockade can occur with vecuronium.
What about analgesics?
We can use intraoperative paracetamol, and fentanyl can be given. Then morphine should be better avoided. Then
Why do you want to prefer fentanyl over morphine?
Because morphine, the metabolite of morphine is morphine 3-glucuronate and morphine 6-glucuronate, and this morphine 6-glucuronate is more potent than morphine, and also it exits through the kidney. And if it's left in, because in CKD patient, it will be retained in the circulation for more hour and can lead to prolonged sedation.
Any
And respiratory
other
depression
analgesic? Any other mode of analgesic you want to give to this patient?
We are given regional anesthesia also. We are given PEC block. PEC 2 block is given intraoperatively.
which block?
Pectoralis block.
Okay. PEC 1, PEC 2.
Like one,
PEC 2 block.
Okay. Any other block that you can use in this patient? Other than
Thoracic.
PEC 1, PEC 2.
Thoracic epidural anesthesia can be given analgesia.
Thoracic epidural, where is it recommended? In which kind of mastectomy?
Ceratizumab.
Mainly
Ceratizumab.
bilateral mastectomy. That's where it's actually recommended. So you have to have bilateral. Okay. In other cases, what is the other?
Serratus antigen block.
Anterior. Okay.
Paravertebral block.
Paravertebral.
Rectus spinal block. Local infiltration of the wound.
Okay. You have practiced these blocks? Or have you seen them?
Yes.
I think there
Pectoralis.
is a demonstration going on here.
X2 blocks.
Okay. Okay. Then Is there,
Sorry.
do you know this patients can be sometimes positioned in a different way? Like
For flaps,
there may be for a flap, there may be position in lateral position. Okay, that's when you should be careful because your lines will get disturbed. You already only have a line in the leg that may be disturbed. Your if you have put the LMA suddenly, if the surgeon says I am going to do a flap, your LMA get displaced. Okay. Right. So at the end of the surgery, yes. Yeah, only 2 moments. At the end of the surgery, how are you going to get this patient out of the theatre? What are your goals when you take this patient to the postoperative ward?
During emergency.
Post-operative, what are the goals?
Post-operatively, first we have to take care of their fluid status because there can be need for emergency dialysis for this patient or to optimize the fluid status and electrolyte balance and acid-base balance. Then need for post-operative post-op analgesia and
Avoid hypoxia.
post-operative adverse cardiac events has to be taken care of because there is high risk for adverse cardiac events during in the post-op period also. Then
Should avoid hypoxia and hypertension during the postoperative period.
What
so residual
problems do you expect the patient
Residual-
on dialysis? What problems do you expect in the postoperative period?
Fluid overload, increased pulmonary edema, will be hyper.
What fluid fluid administration? What was your strategy perioperatively?
Fluid management.
How much fluid? What fluid?
if the serum potassium level is less than 5.5, I would like to use ringer lactate because with 0.9% normal saline, there is high risk for hyperchloremic metabolic acidosis.
Yeah, how much fluid will you use?
Since the patient's urine output is 400 ml per LA, I would like to use maintenance to replace the urine output loss per hour, that is around 15 ml per hour. And along with that, I will like to add the insensible loss. And
How
if
many
there
ml
is
per hour?
15 ml per hour urine output, along with that,
15 ml, she said.
15 ml per hour.
15 ml per hour urine output plus insensible loss has to be taken care of. And blood loss has to be replaced with fluids.
Okay. Blood loss has to be replaced. I mean, it's substitute replacement. Whatever blood for blood you can replace. It is heavy blood loss. But you don't expect any blood loss in this, isn't it? But otherwise, you have to give a minimum amount of fluid. The fluid management should be very restrictive. You need only about 1 to 2 ml per kg. Not 2 ml. Okay. So be very stingy on the fluids. Okay. Restrictive fluid management. Right. Okay. What fluid?
Ringer lactate is preferred if the potassium levels are normal.
Which one?
If potassium level is within normal limits, we will use ringer lactate.
Potassium level is within normal level.
Less than 5.5
How
milligrams.
much potassium is there in
Ringer lactate.
500
Right.
in lactate?
It can rise to
Sorry to interrupt, sir. The time allotted time is over.
Sign off in 1 minute. How much is that? It's about 500 ml contains 2 milligallons. That's not going to produce any hyperkalemia. Okay. In case hyperkalemia occurs, what are you going to do? How will you see it on the monitor?
How will you see in the monitor?
Then ECG changes in hyperkalemia can be first tall T waves, then prolongation of pre-air level, widening of QRS complex, and finally sine waves.
So what did you do? What is your...
First, we have to do cardiac membrane stabilization with calcium gluconate, 10 ml, 10% over 10 minutes. Then we can give glucose insulin drip, that is 10 units of insulin in 25%, 100 ml of dextrose. Then it has to be infused over 15 minutes. Then we can give nebulization with salbutamol, that is beta agonist. Then we can give diuretics if there is urine output. Then ultimate treatment for hyperkalemia is dialysis. So then we can give sodium bicarbonate if there is associated metabolic acidosis.
As far as the tumor is concerned, which anesthetics are supposed to be beneficial? You are bothered about tumor progression in these patients. Which are the anesthetic which are found to be beneficial to this patient?
Propofol is found to have some beneficial. Propofol.
Why?
By promoting the immune system, natural NK cell activity.
BM7, BMP7. It helps. Okay. Is there any other one which produces BMP7 effect? Dexmedetomidine.
Next.
Among the other
Local
agents?
anesthetic.
Local
Local
anesthetic.
anesthetics.
Which local anesthetic?
Bupivacaine and lignocaine.
No. Bupivacaine is not recommended.
Lignocaine.
It's lignocaine and the newer ones.
Propivacaine.
Yes. Okay. I think it's just time is out. Thank you very much. I think it was very well answered by all of you. Thank you.
Thank you, sir.